If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Thanks for joining me on Sunday afternoon, Dr. Reddy. I appreciate it. This is going to be good. So I guess I am wanting to learn more about heart disease. And so we're going to have a couple different guests in to Health Further to really help our audience understand it's the leading killer in America.
Still, after all these years.
You are a cardiac surgeon. You've been practicing in cardiac medicine for how long?
Oh, over 20 years now.
Over 20 years. You're only 25 years old. So and so the hope on this kind of deep dive guest session with Health Further is to really begin to dig into what is heart disease, how do we treat it, how does it build up in our body, what can we learn about it to help take care of ourselves and our loved ones, and then also a little bit of how medicine treats heart disease today and some of the new advancements and where we're headed maybe.
Absolutely.
Before we get started, just tell me a little bit about how you got interested in medicine and specifically cardiac care, and how did you decide to enter the business?
Well, I come from what I would say is a medical family. I'm very fortunate to have a lot of my, well, not just my parents, but so many aunts and uncles. I think we've counted up, last tally, over 26 physicians in my family.
Wow. Yeah.
My sister's a pediatric cardiologist. Both my parents were physicians. My dad's brother, my mother's nephews. But anyway, we come
so
from a long lineage.
In the family.
It's definitely in the blood. But, really, I did chart my own course. But I think one of the seminal moments I remember was as a young kid, and my dad was a pediatrician. And one time going to the ER and watching him sew up a kid who had a pretty big laceration. And although I liked the medical stuff that he was doing in the office, to me, that was really cool to see the immediate results that surgery could have, or a surgical-like procedure. So that sparked my interest. And then certainly summers, I was very fortunate to grow up in Alabama where, ironically, one of the top heart centers in the world existed. In 1966, a surgeon by the name of John Kirkland left the Mayo Clinic and founded a heart surgery program in Alabama and put it on the map. And some of the world's leading surgeons were trained there. And so as a high school student, I had a chance to do some work in the lab there and work in the cardiology department there.
That's pretty cool in high school.
Yeah, and I saw the development of echocardiography, cardiac MRI. So really was fascinating to see all of that develop. I then kind of during college time did some other things. Was actually did some work in the consulting world and investment banking, but always I had that tug back towards medicine. And when I went back towards medicine, I was really attracted to the cardiovascular system because to me it seemed a lot of exciting developments going on there, innovation going on there. But then I also never will forget the first time to see a beating heart and the fact that you could actually work on an organ that moved, because most of the other organs in our body kind of sit still. But this was an organ that was in motion. Yeah. And that was really fascinating that you could work on the beating heart or you could stop it, work on it, get it restarted. And then that began a very long journey. It took me, after high school, 18 and a half years of training to become a heart surgeon. It's a long
That's pathway. Incredible. So you graduate high school, let's say you want to be a heart surgeon. So you have 18 years in front of you.
So typically 4 years of college, right? Yeah. 4 years of medical school. Then I did 7 years of residency, including 2 years in the laboratory, just studying general surgery and cardiovascular physiology. And then after that period, I spent another 3 years of residency and fellowship training in cardiac surgery. Yeah. And then another 6 months in some specialized areas that we'll talk about a little later.
Yeah. Wow. So after 18 years, then you are out and now you start practicing.
And then you become a full-fledged cardiac surgeon, but you never really stop learning, right?
Right.
One of the great challenges that one of my professors at Emory gave me, Robert Guyton, is learn a new procedure or technique or a concept every year of your career.
Interesting.
And we have certainly done that. And you have to do that because the way medicine and science evolve.
Yeah, I think that's why they call it the practice of medicine, right? It's never going to be perfected. You're always getting better and making improvements, maybe making it a faster recovery for the patient or less risk for the patient.
Yeah, that's an area that I've really spent this last several years of my life focusing on in my career is what's called enhanced recovery after surgery. We all recognize that surgery is a kind of trauma on the body. And so we're trying to figure out better pathways of care and better techniques to enhance that recovery.
Yeah. Excellent. And then you've been practicing at HCA for
a dozen years, a
yeah,
little over a dozen years. Yeah, came back to Nashville after a period of time on faculty and doing things in that in the academic medical arena. Came back here to Nashville and joined a really premier cardiovascular institute at TriStar Centennial.
Yeah.
And it's been a great privilege to work with the many talented people there.
Yeah, great. I'm a patient of Dr. Riddick there, so I'm patient at Centennial.
One of my close colleagues.
Yeah, excellent. So I think how I want to start this is to really just lay the groundwork for what is heart disease, how does it progress in the human body. I think often it can start fairly young with atherosclerosis, probably saying that wrong.
Yeah, no, that's
and so I have a couple images I want to get you to comment on for us here.
As you're pulling that up, let's just remind everyone in the audience, as Vic pointed out, heart disease is the number one killer of Americans and really of humanity worldwide. But the other points are that there are three broad buckets of heart disease, maybe four. One is you have ailments of the electrical system, and there's the whole world of atrial fibrillation and other ailments of the electrical system. There's problems with valve disease that we can talk a little bit about. But as you point out, what we're looking at here is the most common ailment, and it does begin many times early in life. We've seen it begin as early as adolescence.
Yeah. So due to maybe somewhat poor diet or lots of just living, you could have inflammation and slight issues with your veins, arteries, all your cardiovascular system.
Yeah, the vasculature really.
So what are we looking at here? This is an artery.
So I think the first thing to understand is let's talk about what are the modifiable and non-modifiable risk factors, right? Certain things just affect your risk of developing what Vic is showing you here, which is atherosclerosis. And atherosclerosis is the disease of blood vessels. The non-modifiable ones are the ones that unfortunately we're all given when we're born, right? It's the gene, it's the genetic imprint. It's kind of what I call the circuit board. And then the modifiable risk factors are the things that are the breakers that you flip on that circuit board and then activate what you see here is that inflammatory cascade. And what I would tell you is that in our modern day of living, that inflammation abounds and it can be triggered by many things. One thing that we often focus on is diet, but it can also be caused from stress. It can be caused from hypertension, elevated pressure in the vessels, and many other secondary causes. But as you point out, once the inflammation starts, it's causing injury, damage, to the lining of the vessel. All blood vessels, as this picture shows here, are made up of three basic layers. There's the intima, which is the inner layer, the media, which is the muscular middle layer, and then there's the adventitia, kind of the outer layer. So, of course, we're talking about the most inner layer. Once that gets damaged by the inflammatory cascade, then it starts a series.
Yeah, so the blood, of course, is flowing through the middle part, and it's right next to the inner layer. What was the name of the inner layer?
It's the lining, the intima.
Intima. And that one, and then the middle one is where the inflammation can grow into plaques, I think.
That's right. So I think in this next picture, we'll see that over time, and like I said, we have picked this up in studies in vessels of even older adolescents, the very beginning of the layering of these plaques. And the plaques are typically comprised of cholesterol, calcium, and white blood cells. Yeah. These all come together, and there are many other compounds and reactions going on here. But that's the biggest thing that happens is there's some damage done to that intimal layer. The damage then results in the laying down of, as you pointed out, some plaque in the wall. And
my understanding is it's like a lot of things in healthcare, it is a reaction to the inflammation and to the slight damage. The plaque actually repairs the strength and sort of makes sure that the structure is okay.
Right.
But if you have too many of them, then it can become really problematic.
Or too thick of one.
Thick of one.
So just like when you break your bone, you have a formation of a callus. It's a kind of a thicker bone around the fracture site. As Vic's pointing out, if you have some small damage to the inner layer, the intima, you may have some plaque laid down so the damage doesn't go through the entire wall of the vessel. But if that plaque now, the inflammation continues and becomes thicker and thicker, or you have things like high blood pressure or other things that are affecting that plaque, the plaque will start into hypertrophy or grow larger.
Yeah.
And that's when the trouble starts, right? Because you can see there's a reduction in the lumen or the size of that blood vessel.
Yeah. You can't, I mean, not everyone will be watching the video, but it's significantly, maybe it's half as wide where those two plaques have grown up. And so it's a lot less blood can get through that one little area.
And we'll see it in the next slide with the cross section. But what's amazing in our bodies is we can live with 50% reductions many times. It's really when it gets to a 70% reduction of cross-sectional area is when people start developing symptoms. So we can almost compensate for blockages of up to 50%. And in fact, the general teaching has been, whether myself as a surgeon or a cardiologist, whether they're putting stents in these blockages or I'm doing bypass, we found that bypassing or stenting arteries less than 50% really doesn't have any major impact on outcome.
With the risk, it's not worth it.
Yeah, the risk outweighs the benefits. You're exactly right.
Okay, so here we're looking at, I think, the thrombus, which is a break off of the a little piece of the plaque kind of breaks off, and then it's floating down through the bloodstream and can be a real danger as far as stroke, heart attack, lots of other issues.
That's right. So if the little piece goes floating and goes into a small end artery, it'll block the entire artery and can result in some real disastrous outcomes for the area of that vessel is supplying. The other thing is stable plaque, you might produce stable symptoms, meaning you got a 60, 70% blockage. You notice when you're exerting yourself, you just don't have the same get up and go and oomph that you used to have. That a lot of people live with. They live with these 50, 60, 70% blockages. However, as you said, when there's a plaque rupture, that's a sudden event. And now you can go from a 60% blockage to 100% blockage because that piece of plaque could go downstream and block off this narrowed part of the artery, or it can cause a certain inflammatory cascade to occur, and you get thrombus forming, and you have a blood clot now inside the middle of an already narrowed artery.
Yeah.
And now you have zero blood flow going to the far side of that artery, and that's your heart attack.
I mean, it's literally like in a stream, if a big log breaks off from a pack of other wood and flows down, it might get lodged in somewhere that is a really fast part of the stream.
Completely disrupts the water flow.
You're right. And so the same thing's happening, but it's inside your body with the blood. So then obviously oxygen can't get to that part of the body, whatever it's being
that's right. Because blood's main purpose is to deliver oxygen and remove carbon dioxide, and that whole process comes to a screeching halt. And that is literally what a myocardial infarction is, or MI, or heart attack.
Yeah.
That's the acute event, is the heart attack.
Yeah, and so a heart attack would be there is a thrombus or a piece of the plaque broken off, and then it goes into the heart and causes trouble in the heart for the heart itself to get blood flow.
Or the plaque it could be a little cap sitting here, and that plaque ruptures. Nothing has to really break off, but it exposes a raw area, and then suddenly platelets and thrombus, and it just clogs the entire
whole
vessel.
thing. Yeah,
that's right.
Yeah.
That's the number 3 that you have there called plaque rupture. Resulting in thrombus.
Right.
Yep. Remember, in the stable situation, when you have the blockage, just the narrowing, you get angina. And angina is that sensation of chest pressure, chest tightness, arm, neck, and jaw pain that you may have with exertion and activities. That's the chronic, relatively stable condition. The sudden onset of jaw, neck, arm pain, or sudden onset of chest pain is typically the acute plaque rupture event that you see here, number 3.
Okay, so then the cross section here.
Yeah, this really shows you what a normal artery should look like, a nice big tube with no disease in it. Over time, you get progression of that. You get development of some plaque formation. You might get a cholesterol cap that can have a little rupture. These little loose pieces can then attract platelets, and then you get the blood clot, now either narrowing the artery to 90% or 100%.
Yeah, that's when so the body can withstand 20, 30, 40, even 50% blockage.
Pretty well.
But as you build it up, you're now getting risk for these other larger events more and more around your body.
Right.
But the more stable plaques you have, the more risk there is that something will
eventually happen. And in most cases, they progress. There are very few studies that have been shown to be able to regress plaques. There's some very advanced diets. There's been one diet that's been shown, but it's a very difficult plant-based diet that most people can't adhere to.
Yeah.
There have been some medications that over time may stabilize plaques, like your typical statins, and even reverse some of this coronary disease. But in general, it's a progressive problem. And that's why it's insidious, because as you build up plaque, a lot of people may choose just to do less activity so as not to get the sensation of that angina.
Yeah,
so they're living with it, and they have advanced disease, but they say, "Oh, do you have any problems, doc?" They go, "No."
Yeah, but they're not able to exercise like they were previously.
That's right.
So their whole cardiovascular system gets weaker and weaker over time.
And that's the insidious thing when you ask people. Well, that's why I always ask the question: are you as active as you were 6 months, a year ago?
Yeah.
Well, no, doc. I figured I was getting older. Well, you get older over like 5-year periods, right?
Yeah.
I can't do what I did in my 30s and my 20s, or my 40s what I did in my 30s. But if something's changed where you can't mow your yard this summer and you were mowing it last summer, you got to start thinking really about something else.
Yeah. Okay. As we have this chronic disease progressing, there's several negative things that could happen. And so I just threw up this picture to prompt you on some different ideas of how would this manifest in a patient for you, or in Centennial with a cardiologist or something else?
Yeah, I think an important concept to remember is atherosclerotic disease, or that whole process in these arteries, although we see it most commonly in the heart, can certainly affect any of the vasculature in our body. So let's say it affects the arteries in your legs, going down to your legs. You might find what's called claudication. That's when you walk and you get cramps in your legs and your thighs. And that should give you alert that, wait, I may have blockages in my leg arteries. You may have it where you get, this is much more infrequent, but if you get a lot of abdominal pain after eating, you may actually have blockages in some of the arteries that feed your intestines. If you have problems with angina, we talked about that's mostly cardiovascular. Right. But if you're getting small mini strokes, or you've had a stroke, well, by definition, you must have blockages either in the carotid arteries in your neck, or in those smaller arteries that go into the brain.
Yeah.
So really, this process can occur to any of the arterial systems.
Yeah. Really, anywhere that is a critical part of the body that doesn't get blood is going to have a problem.
That's right.
Yeah.
In fact, one cause of high blood pressure is when you develop narrowing of the arteries that go to the kidneys. It fools the kidneys into thinking that your blood pressure is low, because the blood getting to the kidney is going through that narrowed artery. Yeah. So that's called renovascular hypertension. So the kidney secretes more and more of this enzyme to raise your blood pressure, thinking the blood pressure it's seeing is low. So you run into this cascade of high blood pressure due to the kidney trying to raise your body's pressure.
Yeah. Okay. Now let's talk about the different roles in the healthcare system. So you're a cardiac surgeon.
Right.
And there's another role called a cardiologist. There might be other ones too. But how should the audience think? How should I think about the differences between those roles? Yeah. And often they work together, I think.
Absolutely. I think more and more in the modern era, we're working very close together, more closely than ever. I think the way you should think about it is a little bit of how you navigate the health system. All of us should have some kind of primary care physician who's taking care of all of our systems. But if the problem or the complexity of the needs of one organ system get to be more demanding, in this case, you're talking about the cardiovascular system, then you would seek out the care of a specialist. As we talked about, if it's a rhythm problem, there may be a specialized cardiologist, an electrophysiologist.
So the rhythm would be the electrical signals, keeping the heart beating in the right rhythm. In the right rhythm.
Yep, yeah, absolutely. So problems like atrial fibrillation or supraventricular tachycardia, or any sort of like what people would call, I'm having palpitations or arrhythmias, may be sorted out and best treated by an EP, electrophysiological cardiologist. The other problem, maybe we'll talk a little bit about this a little later, is heart failure. There are cardiologists that specialize in heart failure. And then there are good general cardiologists that may be specialists in treating the high blood pressure or low blood pressure. And then you have what are called structural cardiologists and interventional cardiologists that now use advanced devices and tools and techniques to treat those blockages in heart arteries and heart valves. And in some cases, when they can't be treated by those more minimally invasive or less invasive techniques, then you have the role of the heart surgeon. We typically are trained and have expertise in the open or surgical repair of many of the heart ailments. So the typical procedures I would perform would be bypass surgery to bypass those blockages, heart valve repair or replacement to fix the heart system, and in some cases, even ablation procedures to fix rhythm problems. And then certainly the repair of holes and other defects in the heart that one may be born with or have developed over time.
Okay, so just to recap, the cardiologist, and there's a couple of different types, EP, structural, but the cardiologist
Imaging,
is
the ones that specialize in making pictures of the heart.
That class of doctors, they are treating patients with medicines, or they're treating intravenously through their veins
and arteries,
as opposed to a cardiac surgeon, where now you're putting the patient under, they're in the operating room.
That's right.
And often you're putting the patient on a heart-lung machine and stopping the heart and actually opening them up like we would imagine a classical surgical procedure.
That's right.
Cardiologist does not do that typically.
No.
They would be working through the vein or artery.
Correct.
And they have I think of it as like a wire, like a guiding
tools,
wire,
catheters
and the
wires.
catheters, and they go, and they can do a lot of work because they're working
and balloons
on the cardiovascular system. You can get a lot of access through the veins and arteries.
Exactly.
And that's where they're working. They're putting a stent in or whatever is required.
That's right. And they've been very successful in treating many, many aspects of heart disease through those techniques.
Yeah.
But what we've learned through the years is there are some cardiac conditions that are better treated initially with those techniques, but there's a whole host of other things that are treated better initially with surgery. Mm-hmm. And then there are even those procedures we're now developing that are treated with a combination of both.
Yeah.
And those are called hybrid procedures.
Yeah. And so let's talk about why the valve system. So I guess there's several valves in the heart.
Yes.
And the heart has 4 chambers. There's a valve.
And 4 valves.
For between each one.
Mm-hmm.
And the valves have to open and close exactly at the right time and seamlessly so that the blood can go through, but then they stop the blood from back flowing.
That's right.
And it allows the chamber then to fill up for the next
cycle.
Cycle. And so if the valves are not functioning, not opening correctly, not closing correctly, that can be a significant problem. So there's I think you said there are 3 major classes of problems. There's the electronic wave, like is the heart beating correctly?
Right.
There's the valve. Some of the valves, 1 or more of the valves are not working correctly.
Right.
And then there's the atherosclerosis, the thing we started with the veins deteriorating.
Blocked arteries,
yeah. And so let's talk about the valve replacement. And I want to talk about the traditional one first. I have this little video here.
Oh, great. So I think what this video is really trying to depict is here you see a rib cage, you see the beating heart, and you see kind of a line in the middle through the sternum. This is the sternum here.
Yeah.
And really what we do as a heart surgeon is, you hear this terrible term called we're going to crack the chest open. We don't crack anything open. The ribs are left intact. We make a surgical incision through the sternum.
But you do
divide
the sternum.
The sternum. Yeah. We make a surgical incision through the sternum, and that gives us full exposure to the heart. You can keep letting it play through. A misconception a lot of people have is that when you do get into the heart's sitting right there. No, it's sitting in a sac that they showed just a second ago. We open the heart sac. Then we use a series of catheters or tubes or what we call cannulas to connect to the heart arteries and veins. And this lets us put the heart on the heart-lung machine. So now we have connected the heart in this picture to the heart-lung machine.
Yeah, so that's a machine in the operating room.
Correct.
But it is going to perform the action of moving the blood through the body. So the heart can...
2 things it's going to do, right? It's going to pump blood through the body and keep the pressure and the perfusion, the kidneys, the brain, the liver, all of that's still going to have blood flowing to it. The only organ that will not have blood flowing to it would be the heart. The second thing it allows us to do is also stop the heart, because now we will give a special solution to the heart to arrest the heart. So you want to continue. It shows it going from a beating state right here, but we've got to work on either these arteries or the heart.
Yeah, so now they've stopped it, right.
So we've stopped it by giving a special solution. That allows us now to access the structures inside the heart, like this diseased heart valve, by making incisions into the blood vessels.
So let's talk about this valve right here. Like, it looks to me like it's not fully closed. So
that's right.
So
this valve
part of the problem is
malfunctioning.
And And so it doesn't, in this case, maybe it doesn't close all the way.
And it's probably not going to open all the way. So it's become very stiff and dysfunctional. And I think you have another video that probably shows a lot more on that heart valve.
Yeah.
But this allows me to access the heart valve. The still heart also allows me to access the arteries on the surface of the heart.
Yeah.
But you saw at the end of that video, they were about to implant a surgical heart valve. And we would take a series of sutures, as you see here.
Yeah.
And now we're putting in a brand new heart valve and replacing the one you pointed out was diseased.
Okay, so let's talk about this image. So the valve is being placed in there.
Mm-hmm.
And how big is it? Is it the size of a quarter? Is it
between
dime?
a quarter and a half dollar? Between
Okay.
a quarter and a half
Okay.
dollar size. It's typically a valve that's mounted on a fabric and metal or plastic stent.
Okay.
And the leaflets are comprised of either cow or pig tissue.
Okay.
So in most
The
commonly,
leaflets
we're
are
putting
the
in-
part inside the valve that are opening and closing.
close,
Yeah, right.
Now, in some cases, we could replace in a young person, if we want to avoid any future operations, what we call a mechanical heart valve. And these are leaflets made out of pyrolite carbon that are harder
Okay.
than steel and open kind of like a flapper valve. Now, the advantage of those valves is they never wear out, whereas a cow or a pig valve eventually will wear
Okay.
out. But the advantage of those flapper valves, they never wear out. The disadvantage is you got to keep them lubricated just like your valves in your car.
Huh.
So like you put oil in your car,
Yeah.
you've got to take a special medication or blood thinner called Coumadin or warfarin. So now the rest of your life, you have to take a
Okay.
blood thinner or an oil to lubricate that valve. And a lot of patients don't find
wanna-
that want to do that.
Okay, and then the valve, does the valve come with the sutures already
that's the
queued up
surgical
like
technique.
that?
No, we that's the
Did you do
art
that
and the
ahead of
skill.
time?
We do it right after we cut out the valve. So we
Okay.
cut out the old valve, we put in the sutures into the patient's body, and then we pass those same sutures through the new valve.
Okay.
And then we call what we call seat the valve
Yeah.
in
So
there
like
and
here,
then secure it
the sutures have been put into the body
into
first.
the body. Then they've been put in through
then
the
they're-
valve.
And then you
they're
sort of
gonna
like push it down along the
and then
sutures.
tie it in.
Kind of, yeah.
lock it in place.
Yeah, interesting. So your technique is to put all those sutures in the right spaces around the
Annulus, it's called.
the
Yeah,
annulus. Yeah, and then you can do the valve a little bit away and then push it into the exact right place.
That's right.
Yeah. Okay, so that is a valve replacement done through an open procedure.
Yes. Just like
And
we talked about at the
That's
beginning
been
of the video.
done for
Over 55 years.
for a long time. But you and others started working on trying to do this minimally invasively. And I
Yeah,
want you
really,
to talk through that so I don't say it incorrectly. But the
Sure.
TAVR procedure, TAVR.
Yeah, which stands for transcatheter aortic valve replacement,
Mm-hmm.
as opposed to SAVR, surgical aortic valve replacement.
Okay.
What was really the genius of Dr. Cribier and others in France, sometime in the late 2008 to 2010 period, was the concept of understanding, just like we put stents in arteries to open them and push that plaque to the side,
Yeah.
could we come up with a technique to mount a valve on a stent and using a balloon, crush the old disease valve to the side and now put in a functioning heart valve?
Yeah.
And this was really a revolutionary breakthrough. And I have to say the speed of it moving from first in human to then commercial availability around 2011 and 12, and our adoption of it in Nashville in 2012. At one time, we being the only city in Tennessee doing these procedures at the 3 centers here in town, to then now in 2024, 12 years or so
It's
later,
much more
it's
common. Yeah.
almost every major city in
Yeah. So in
Tennessee
10
and
years, it's gone from,
highly
very-
specialized
yeah,
centers,
into-
specialized trials
yeah.
to everywhere. And
Yeah. So instead of opening the chest, putting the patient on a heart and lung machine,
we can do all of
you
this.
do all of that.
with the patient not even fully asleep, just with what's called conscious sedation.
Yeah.
Meaning they're in a very light sleep. You can
Okay.
cue up that video
Yeah.
and we'll
Yeah.
go through
So,
it.
yeah.
So I think this video will show a lot of the concepts we're talking about. The first concept is understanding what is aortic valve stenosis. And Vic, you were kind of commenting on, what do you notice about this valve right there? There's the normal valve.
Yeah.
So you can see how it's opening.
Right. It's opening quite wide, letting blood go through.
Yeah, leaving the left ventricle. This is the
Yeah.
main pumping chamber of the heart. But then what's happened here?
Yeah. It's narrowed. Doesn't open as much.
And typically that happens because the disease state here is calcification. Rather than plaque, it's the deposition of calcium. So the valve, instead of opening nice and widely,
it's not as flexible as
that's right. It becomes very stiff. So now what you have is reduced blood flow getting to the body. And you also cause a thickening or a hypertrophy of that left ventricle.
Yeah, it has to almost work harder continuously.
Yeah. And look at the symptoms that occur. You get people short of breath. You get them really fatigued. They stand up very quickly. They could get lightheaded or
just
dizzy.
from that valve not being able to fully work.
Let the blood out. Right. And then in the really late stages of that condition, you can get swelling and even fluid building up in the lungs. So again, a normal valve opening large, a diseased valve opening very narrowly, causing it. So how do you diagnose it? How do you figure all this out?
Yeah, like if a patient comes in, how do you know without being able to see them? So here's the
first step. They kind of skipped in this video, but of course, a doctor, we still do use those antiquated things called a stethoscope. Yeah. So I might listen and hear what's called a murmur. Now, if I hear the murmur, we then go and get this test done, which is an ultrasound.
Okay, so you can hear a suspicious murmur in the beat.
And the murmur is actually that abnormal blood flow going across. When you see this kind of turbulent blood flow, that produces the murmur. So now we can take that echocardiogram or that probe, put it on the surface of the heart, and we can see the chambers of the heart. We can see a diseased heart valve, and we can see if valves are leaking or if they're too tight or stenotic. So this ultrasound probe can shoot those ultrasound beams.
You can do that right in your office.
To be done in office. It's an outpatient procedure. Doesn't take. Yeah. So now what you're seeing here is the end result of a TAVR procedure. Again, we have a narrowed heart valve. Yeah. It's not opening. But here, instead of now making that open chest incision that we heard about and talked about, we have this other technique to try to treat this abnormally functional valve. So we want to restore this nice picture in this situation. So
without opening up the chest and going through all of that.
So how do we do that? It's done through this transcatheter technique that was developed. And that technique involves ultrasound. It involves fluoroscopy. So a patient first undergoes a CT scan to see if we have adequate vasculature to access the heart valve.
Yeah, and really find where are all the veins and arteries that you could go through. Yeah.
So then you take a needle and you put a wire and you thread that wire through the diseased heart valve. What we had here was the groin. That picture before was the groin.
You went through the patient's groin and then
threaded a wire
up through their
aorta,
their chest, the aorta, and then almost down.
Yep, back over the arch and down through the diseased valve.
Yeah, over the arch and down into the valve. And there's a wire, might be hard to see for people listening, but there's a wire that starts that you kind of feed up through the artery. That's right. All the way up to the aorta
and through that diseased valve. That's a pretty tricky step.
Right, because
it's narrowed. The valve is narrowed.
Yeah, so by definition, so
it's very tricky to get that wire to cross that valve in the backwards way. But that allows us, and that acts as a monorail. So now you've got a way to access that valve with many other catheters and techniques.
So then you can bring other things along that wire, along that monorail.
So that wire becomes your main kind of monorail, your guide to doing everything else.
Yeah.
So that's a very important step in the procedure. The other step you'll see here is there's a catheter being put into the other side of the heart that allows them. Remember in the open heart situation, what did I do to work on the heart?
You had to stop it. Right.
That's right. But here we're not going to be able to completely stop the heart, but we can make the heart quiver with that pacing wire. So it's effectively a brief period where the heart is not pumping and squeezing because you can't put a valve in there while it's still squeezing blood out.
Right. Yeah. So you don't turn it
we fibrillate
off
the heart.
Totally, but you fibrillate it so it's not beating very aggressively.
It's not beating at all. It's really just quivering.
Yeah.
Yeah. So then, as this picture shows, we've now over that wire threaded a valve inside a sheath or a catheter.
It's like all folded up.
That's right.
And then you'll balloon it out in a minute. Yeah.
So then we're in this particular valve type, we're able to unsheath the valve. And now here's the pacing. So now the heart is quivering rather than beating. During that brief period of quivering, we unsheath the valve and it pops open. It's made out of a special metal called nickel titanium. The other technique is one you mentioned where they balloon it.
Yeah.
And those are two techniques we use, and we do both to put the new heart place. Then we stop the pacing. Heart starts beating again.
And
we take out the wire. And now look, we've restored that nice open thing, structure of the valve. So we went from this, now we're back to this, from a narrowed valve to an open valve.
Yeah.
But, even with this technique, there are risks, and we're really trying to reduce these risks. One of them is some of those pieces of calcium could break loose and cause a stroke. Mm-hmm. So we've now developed a technique through the arm. We can put filters in the arteries that go to the neck and brain to catch any of that debris. So we're doing that routinely. We've also found that sometimes these catheters can puncture the heart. So we've done things to reduce that risk.
Yeah. And so talk about the impact to the patient outcomes.
Well, number one,
it's
it's
significantly
expanded.
better.
It's expanded the patients that we can help. For example, if you were 80 years old, none of those patients were looking forward to any open surgery.
Yeah.
And they'd really be given a terrible, sentence of they may be fine in every other organ, but now you're just going to develop heart failure and have a miserable existence. But we can take a 75 to 85-year-old. Our oldest is we did one on a 100-year-old. Wow. You can go through the groin and put these valves in and take care of very straightforward problems. That's not going to make them Superman, but all those symptoms we talk about are going to be alleviated.
Yeah, right.
The heart failure, the swelling, the breathing problems. You can restore this without them having to spend more than a day or two in the hospital.
Yeah, and so because it's minimally invasive, but really not even very invasive because you're going intravenously, it's a really fast recovery time.
Yeah,
right?
Yeah, because you're going through the vessels. The biggest thing they got to heal from is that puncture site in the groin.
Yeah, right.
Yeah,
right.
It's a much different healing process than trying to heal the bone of your chest.
Yeah. Okay. And you typically partner with a cardiologist in this?
Oh, absolutely. This is what I would call a heart team procedure.
Okay.
This is a procedure that we come together as a heart team, cardiologists of very multiple specialties, imaging cardiologist, invasive cardiologist, and occasionally we call in our EP specialist as well. Because some of these patients sometimes need pacemakers before or after the procedure. And then the cardiac surgeon, we make very precise measurements. We make a really healthy determination whether the patient's better served with a surgical strategy or this catheter strategy. And it's not based solely on age. There are many other factors that go into it. And then we work together to give the solution for them.
So there's some times when the open procedure is still better.
Absolutely.
Yeah.
Absolutely.
Okay.
Yeah.
It has to be the right situation for maybe there's a particular valve that works in this way.
Right.
But not as many options for it.
Well, the optionality, one of the things you might notice is when you put this valve in, you don't cut the old valve out.
Yeah.
So you have a little bit of the Russian doll phenomenon. So if we have to come back in the future, because this is made out of tissue, and in 6, 8, 10 years when it wears out, we're now talking about the lifetime management of aortic stenosis and valve disease. So what that fancy term means is, well, if we do this time, what are we going to do in 6 to 8 years? What are we going to do that 6 to 8 years after that? That's why when a 45 or 50-year-old comes to us and says, oh, I just want the TAVR valve, we're saying, but wait a minute, you're only 50.
Yeah.
When you're 60, have you taken a lot of other options away from yourself?
Because it only will last 8, 10 years.
Now, either valve may not last as long. So we really want to give them the most optionality, not only at this interval, but what in the 10 years and the 20 years after that.
Yeah, because you are doing it through the veins, it crushes the old
valve to the side.
Tissues to the side. That's what you want the Russian doll. You can't do that
too many times.
Right. Yeah.
Right. So what we've really shifted to is in the younger, healthier patient, get the surgery now.
Just go ahead and do this where you can tolerate it.
And recover from it.
Yeah.
Save the TAVR procedure when you're 70, 80, 90 years old.
Yeah.
It's the ideal procedure in this octogenarian.
Yeah.
It's been transformative for what we can do for aortic stenosis in 80-year-olds. 70-year-olds, I'd still say the majority get the TAVR valve. 60-year-olds, I'd say we've shifted back to majority getting the surgical valve.
Because then they'll come back in 10 years.
If they go with the tissue valve choice. Now, remember, you still have the choice of the mechanical valve and never need another forever.
Yeah, but then you're taking daily
blood thinners.
Yeah. Okay, and then people talk about robotic surgery.
Yeah.
These
guys.
I think
this is the part that gets a lot of people excited, right? So the first thing we want to point out in this picture, Vic, is what you had mentioned early in our talk is the heart-lung machine, and that's there to the right.
Yeah, right.
And so you still have the heart-lung machine. You still have the red and blue tubes connecting to the patient to stop their heart. What's different you see in this picture, however, is the surgeon is sitting at a console to the left rather than at the patient, but you still have to have surgical assistants now dock the robot to the patient. And really what robotic surgery brings to us is another tool. It's a tool that improves visualization and allows us to do work on the heart through smaller incisions. That's really the advance of the robotics. It's still what I would have to say, not investigational or experimental. What I would say is that it's still in its early days, and we're still trying to figure out who best benefits from this procedure.
Yeah, and when do you need that? It's almost like a virtual reality, significant magnification for the surgeon, but the difference is now you're at a distance.
That's right.
You're not
right at the patient.
Directly hands-on.
Yeah, we're finding that for certain valve ailments, such as mitral valve disease, this may be a real advancement because it allows us to visualize that valve so much better when we want to effect a repair.
Yeah.
So this is when you're repairing the valve and not replacing it. You may have to do a lot more things to try to fix that I think the robot may offer a significant advance.
Yeah.
We have seen the robot bring big advancements to other types of surgery. For example, surgery deep in the pelvis, prostate surgery, GYN surgery, because it can reach that hard to get to place a little bit better than even than laparoscopic or traditional surgeon hands.
Tell me where you think this is going. Like, you've been practicing for 20, 25 years. I think we're seeing a decent amount of changes in the treatment of heart disease over that time. And where do you see it going? And what are you hopeful about, and what's maybe makes you a little concerned going forward?
Well, I guess one area of concern is I don't see it going away.
Yeah.
I think heart disease is with us. The good news is that the arsenal of tools that we have are growing and getting better and more advanced. One thing that's come out of kind of left field that's had a huge impact on the cardiovascular side are the GLP class of drugs.
Yeah.
All of these drugs that were originally thought to be for diabetes and then had this big wave of adoption and excitement regarding obesity are turning out to have maybe some real salutary effects for cardiovascular disease. So I'm excited about that.
Yeah.
We've also had, so I'm still very excited about the drug therapy, the medical therapy of heart disease. There have been a whole nother class of medications that have come out that have been shown very effective at combating heart failure. Both heart failure where the ventricle is starting to peter out, and even in heart failure where the ventricle is just not working well and relaxing well. That's been exciting. Then on the interventional side, I think the stents, the catheters, the tools to treat all of the stuff we've been talking about today continue to evolve and get better. So we have better stents, better heart valves, better techniques to treat atrial fibrillation through catheter-based therapies. And then finally, on the surgical front, I think you're seeing adoption and development of more minimally invasive techniques, the concept of the enhanced recovery after surgery I mentioned, where we're understanding the surgical journey is one that does inflict trauma on the body, but that we may be able to reduce it by preparing people better for surgery, performing better surgery, and then helping them recover after surgery in a more, I would say, protocolized way.
Yeah, it's exciting. I'm going to do probably 3 or 4 sessions like this with different experts in healthcare.
Wonderful, yeah.
I think we'll maybe talk about disease prevention and diet and exercise, and how can you prevent or maybe forestall the progression of cardiac disease. We'll try to get someone, maybe a cardiologist, so different experts in that can bring different points of view to things. But it's such a big issue in our society today. And I have heart disease, not late stage, but I have heart disease, and it's hard to get easy to access information. There's a lot of very scientific information for doctors, and then there's very high level information, like on the American Heart Association website and things, but not that middle ground where you dive in a little bit deeper.
I agree. I think that's important about things like this podcast. I mean, part of what we as doctors, the term doctor in Latin, of course, means to teach. And I really do think one of the important roles of a physician and a surgeon is to teach patients and inform patients and educate patients. I always tell my patients when they come to my office, I'm not here to talk you into anything. I'm not here to sell you surgery. I'm here to explain to you your disease state and some options that you have.
And then you can make the decision.
You make the decision if you feel like surgery is the right option. Having said that, I also think what's exciting is the world of health information technology. I think just innovation in healthcare in terms of everything from the way we get that information to the patient, the way that apps and other things like these watches you and I wear can monitor the patient, and the way that we can affect the patient's health journey, whether it's little teasers to tell them, hey, don't forget to walk today, or did you take your medicine today, or teaching them to do the right amount and quantity of exercise in a day, or monitoring what foods they're putting into their body and what class of foods those are.
Yeah, it's all interrelated. So as we learn more how what I eat this afternoon is going to affect my health tomorrow, I can now make a better informed decision. I still may want to eat it, but at least I know what I'm doing.
I'm really seeing that in the area of diabetes and blood glucose management. It's been remarkable how patients can get real-time feedback on, hey, when I eat this kind of bread versus that kind of bread.
Yeah.
This is the jump and bump I see in my blood sugar.
Yeah.
Wow, when I exercise or I don't, you may see like this is your VO2 max for your cardiovascular fitness. So I think even these little step counters and all that. The main thing I think for our audience and others, remember, who are combating heart disease is don't get disheartened and think that it takes a lot. It's just a little bit can make a big difference. We're finding that you don't have to hit the gym for an hour every day, but 30 minutes of walking can have 80 to 90% of the benefit.
Yeah. Yeah. It's just getting up and doing something
Rather than nothing.
makes a big difference.
Same thing. No one has to go out and you're eating just spinach leaves all day long. I think it's the understanding if you make just better, safer, more educated choices of what you purchase in the grocery store and what you purchase when you eat out can make big differences.
Yeah. Great. Well, Seenu, thanks for doing this. Really fun. I may have you back at another time to talk through things, but we have a lot to learn in cardiac disease. Learned a lot today. It's good.
Well, thank you for having me, and it's a great privilege to be able to help people out there.
Yeah.